From the back, any question from resident especially? Yeah, Kate.
Eric, I'm a liberal shunter. So for normal pressure hydrocephalus, I now go entirely on clinical grounds. I've stopped sending them to the neurologists, and I've stopped doing a lumbar tap test since I've seen it positive in a number of non-normal pressure hydrocephalus diseases. And I've told the patients that I'll shunt them with about a 50% chance that they will improve, which I think it's more than that, but that's and I think given now that you can treat the complications with a programmable shunt, that's reasonable. What do you think? What do you actually do? You showed us a lot of data, but are you a liberal shunter or what do you do?
No, I'm not a liberal shunter. I will still do the TAP test. And you see, one of the big differences between the way that you practice and the way that we practice is that our patients usually shoulder the expenses out of pocket. And so when you offer surgery, especially for something like a programmable shunt, which is quite pricey, you have to put a monetary value to the surgery, and you have to assure the patient. You have to give a reasonable assurance, a rather high assurance. Our barrier for acceptable assurance is probably higher than yours. That we have to assure the patient things are going to be okay. I'm not going to give you a subdural hematoma, and you're going to spend a lot, but it's going to be worth it. And so I still do a TAP test.
So Eric, in your practice, so do you offer endoscopic tape ventriculostomy or no at all? Okay, if you offer shunt, is it programmable or standard differential? Which setting that you start with?
I will offer a programmable shunt, which I don't do the math very well in my head, but a regular shunt costs 15,000 pesos. A programmable shunt costs 10 times as much. So it's a considerable expense. Now we use the Strata valves, so I'll set them a little high, 2.0 setting, and then I'll tell the patient, go home, see what it's like, and see me after 2 weeks. And in essence, if you feel that you're getting better, but you haven't gotten better enough, then I'll lower the setting to 1.5, go home, 2 weeks again, come back, and then how do you feel now? And if they say, I'm improved, but still not complete improvement, then I'll lower it again. But if the patient starts saying, whenever I sit up, I get a headache, I feel dizzy, then your pressure is too low. Then I'll raise the pressure up again. So bring it, and it requires several adjustments.
Do you need to do revision in your series?
Oh, thank God, no. Thank God, no, because the revisions are expensive.
How about in Vietnam? Yeah.
I was going to ask the same question. I'm interested to know how things work in Vietnam with shunts, costs, and what the cost and what the practice is generally for normal pressure hydrocephalus.
You talk about the cost of shunt in Vietnam? Yeah, very expensive. Yeah, and so I have a question about the normal pressure hydrocephalus. In Vietnam, maybe the patient stay too long in the department of neurology. I don't know. Everywhere. Yes, how we can improve this situation?
Talk to the neurologists.
I think that the problem is they don't trust us. So we have to communicate to have good results. And I think in the past, the problem has been the complications of the shunt. I think that will change a little with programmable valves because the risk of the subdural is very much smaller. But they're not going to refer patients if they don't think it will help. It's been the same with DBS, really, hasn't it? I mean, it takes a while to get, they've got or epilepsy surgery. They have to believe that it will work.
How reliable are the MRI flow studies, the stroke volume across the aqueduct and so forth? in diagnosing normal pressure hydrocephalus? Because
Oh, I had a whole segment on that, which I had to cut on in the interest of time. That the people have been looking for a non-invasive test, which will predict a response to normal pressure hydrocephalus, and they haven't found it yet. Also, my wife, who really holds all my money, computed that the cost of in the Philippines, the cost of the regular shunt is 5 million dong, whereas the programmable shunt is 50 million dong.
Okay, any other question? Yes.
So I have two questions. First question about the key rim information for Dr. Legaspi and Dr. Yuen. So compare with the theory decompression with or without neuroplastic, about the outcome of the neurological improvements, it looks similar with or without neuroplastic, but the complications very different. Without neuroplastic, it's nearly zero, but with neuroplastic, higher, maybe over 10% with the meningocele, with the meningitis, or too many other problems. So what do you recommend for the first option of the key rim information for K1? And if we fail, how can we do next steps?
Well, thank you for that. Anecdotally, from my own practice and also from my reading of the literature, surgery is much more beneficial if you have a duroplasty, without a doubt. Whether it's to do with patient selection for all the studies that I've read, or whether it's to do with the actual surgery itself, I think certainly a duroplasty has much less risk of recurrence or need for redo surgery invariably than if you do the duroplasty, that the patients will have a better outcome for sure. And yes, you do have the increased issues of CSF leak and pseudomeningocele, etc. But I think certainly if you use an autologous like a periosteal graft, that you'll have a much better outcome as well. And good watertight closure, good surgical technique.
what's the incidence of cerebellar ptosis following decompression, for ion magnet decompression, and how would you manage a case of recurrence? I mean, symptoms persist and you do an MRI and you see the tonsils are still herniated. So what would be the second?
Yeah, I always actually cauterize those tonsils, so I must admit I haven't had a case so far. There might be more experienced surgeons that have had that. I haven't had a need to go back.
That's one of the complications they say, especially if your bony decompression is a little too much, then you have this cerebellar ptosis.
Oh, sorry, I thought you said tonsil. Sorry, yeah. Well, you can go back in and put a bit of mesh to help try and support the cerebellum. Is one of the recognized ways to help with those symptoms. Yeah, I guess if you keep it to 2.5.
How would you manage that case? A case of cerebellar ptosis, as well as a patient who does not improve, and you do a follow-up MRI and you see the tonsils are still herniated. So what would be the next line of management?
Well, I guess because I cauterize the tonsils, I don't see that. But if that were to happen, then I would go in and I would cauterize the tonsils, do a bigger craniectomy. With the cerebellar slumping, you can go back in and put a bit of mesh to try and hold up part of the cerebellum. Usually if you've taken off too much bone is the issue. So I keep the craniectomy to 2.5 to 3 centimeters.
I believe another way. I've never had it either, but I've had a colleague who has, and the way they managed it the second time round, the cerebellar slumping is a combination of, holding the cerebellum with some mesh, but also shunting. So by shunting supratentorially, you're taking the pressure off, and you're allowing for that.
Thank you.
Home time.
One more question. Okay. One more question is for everyone to discuss about the what kind of position for the valve. So about the standard valve or programmable valve in normal pressure hydrocephalus, programmable valve is very good. The first choice, but I mean for the others hydrocephalus, especially in children. How about your experience about programmable valve? Because the cost of programmable valve and standard valve very high is the different here. So please.
Yes, I don't believe the people from the companies who tell you that, oh, this valve, it's anti-siphon, and this valve, you can turn the child upside down and nothing bad will happen. And this valve is flow controlled and this valve is pressure controlled. In most cases, a simple flushing valve shunt will be fine. I put most of my shunts in for patients with tumours or trauma or subarachnoid hemorrhage, and those patients, a simple shunt, non-programmable, is absolutely adequate. And this obsession in rich countries of putting in the programmable is crazy. Now, in anyone who's prone to a subdural, the advantage of the programmable shunt is that you can basically switch it off. But you can also just tie the shunt off as well. So it's not essential to have a programmable valve. And in a resource limited setting, it's really in many cases unnecessary. And what you should really be putting in is the Indian Chabra shunt, because that is the cheapest shunt that there is available and it works perfectly well. And that should be all over the world.
Sorry, I think there's another advantage to putting in a programmable valve. So one is the subdurals that Eric mentioned. Other one is that you don't know what pressure your patient will function best at. So with no pressure hydrocephalus, some patients function better with a low pressure valve and some with a medium pressure valve. And so you avoid a second operation by putting in a programmable, because you have the options of adjusting the pressure so that you get the right pressure that works for them, but avoiding the subdurals. So there is an advantage of that as well.
I mean, I agree in normal pressure hydrocephalus, there's some advantages, but you still don't need it. And there is another way without the tap test that our old boss used to use. So if Professor Kay was here, he would say that everything that everyone said is complete rubbish. And he would say, if you suspect normal pressure hydrocephalus, and this is a very invasive way, obviously, didn't believe in the tap test. If you suspect normal pressure hydrocephalus, do intracranial pressure monitoring. If the pressure is very low, the patient does not have normal pressure hydrocephalus and they will not improve with the shunt because you can't possibly drain CSF. If your pressure is 2, no shunt will drain CSF. If the pressure is normal, 8 to 12, then he would put in a shunt, and generally a low pressure shunt, because that's what's going to drain CSF. So there are other ways of doing it.
You also look for beta waves in the early morning,
I can never see those. But I still do intracranial pressure monitoring sometimes in patients who are not sure whether they want a shunt. If the pressure is very low, they won't get better. I don't take CSF off with the intracranial pressure monitoring. I look at the steady state. No, I don't think so.
Yeah, I very much believe in the tap test. I think there's a high correlative thing with the positive tap test and the success of a true normal pressure hydrocephalus patient. When I put the shunting, I actually take off about 40 mils at the time. So usually straight after, I ask the patient, how are you feeling? And if it's success, obviously, then they'll say, yeah, I feel great. And they do feel great walking around.
That's the anaesthetic that makes them feel better. It's the drugs.
It's not. Yeah. Very controversial.
Okay, any other question? Because we have 2 options. Oh yeah, question. Because we have still half an hour. Either we take photo and we go back, but there is a question at the back.
I have one question. We know in the world we have antibiotic in pregnant vans, and so I want to ask in your country, do you how often do you use this van, and do you have any study about evaluation the efficiency of this van, and
Yeah, we're very lucky. We would almost always use antibiotic impregnated catheters. There is level 1 evidence to say that it reduces the risk of shunt infection, but it's very expensive. But we would use all the time impregnated catheters, but that's because we're lucky in Australia. What about Philippines?
No, we're not lucky at all. We use the regular tubing. We try to keep our infection rates down by when you're doing a shunt, you become psychotic. You get instruments, and anyone who tries to enter the room, you throw the instruments, and then make sure that nobody enters the room. And so far we've kept our infection rates down. But the Bactiseal tubes really do help keep infections down. We just can't afford them.
thank you.
Any other question, especially to the trainees? This is very big opportunity for you to ask the expert.
Everyone's looking a little bit tired. Are you tired?